Good afternoon again, everybody. This is Leah Baza. Again, thank you so much for joining us. Today is our fourth Practice Manager Learning Community. As you know, today we'll be talking about billing and coding related issues. I'm thrilled that we do have with us a professional on the line, Jim Tudor, who will give us a presentation later on this afternoon. As always, if you have questions, you can feel free to unmute yourself, or you can send chat in through the chat feature. Anna Porter is here with me and she will be managing those messages. So feel free to make this as interactive as we can, even though we're on a webinar all nice and cozy in our offices or wherever you're attending from today. So today, to just look quickly at the agenda, we do have a short part that I'll be speaking to about the Affordable Care Act. And I want to preface this saying that I know most of you are very familiar with it, but because we're talking about some coding and some preventative, I thought it would be a nice way to kind of get everybody to speed on what exactly it is and what it entails and what does that mean for our patients. We do have some coding modifiers, incident 2 discussion happening today. Again, I have a speaker on the line who I'm thrilled could join us to talk to us about his expertise in these areas. And then we have some billing policies and best practices that we were looking to share with you. And finally, we'll talk about the deliverables, also known as your homework. And so quickly, if you have any audio sounds, please let us know. We just want to confirm that you can hear us okay. We are recording the meeting so that if you have anybody at your practice that couldn't attend, we'll be able to share the information with them later. Perfect. And you knew it was coming. I always do it. I just need to remind you all about Open Pediatrics. That is our discussion forum for practice managers. I'm happy to say that the utilization has gone up. We have some interesting conversations going there. Practice managers sharing best practices with each other, asking questions. I do plan to keep the calendar up to date. I know there's a lot of events that go on across the PPOC and at your practices. And so this is a tool where we can keep all our practice management related items in one place for you. As always, if you're interested in joining Open Pediatrics, you are required to create an account on Open Pediatrics and then let myself or Emmy Llewellyn know so that we can invite you into our practice management board. This is a private board, so you have to be invited into it. And then on a side note, I'm thrilled to announce that the MHCCs are now starting to utilize Open Pediatrics as well. And so if you're a practice manager who also has a dual role and does care coordination at your practice or are interested to join that, you are also able to join that one as well. I believe there's been information shared at some of the longitudinal meetings. It's in the roundup, and MHCC communications give you more instructions on that. So I'm happy to see that being used outside of the practice management staff and hope that your practices find it useful as well. Okay, so again, today's our fourth webinar. I'm thrilled to say that we have no event scheduled for July and August, so hopefully we can all take some time to have a breather, maybe take a vacation, spend some time at the beach. Our next webinar, our next learning community after the summer is Wednesday, September 11th. We do have Schwartz and Hannum employment attorneys attending that one, and we'll be looking specifically at employee handbooks. So I'm really excited about that, and hopefully many of you, if not all of you, can attend. That will be an on-site session, as always, held in our 3 locations, and the goal is for you to bring your existing employee handbooks, if you have one with you, and go through that with these attorneys. Our October session, we have not come up with a topic yet. We have a couple topics we're trying to decide between, and so you'll hear more information about that at a later time. Great. And so I wanted to just quickly do an overview of the Affordable Care Act as it stands today. As most of you know, the Affordable Care Act was created back in 2011. It's also known as Obamacare. And the point was to ensure that all Americans have access to affordable health care. And so the way that it works is that there's discounts, which are basically tax credits, for people on government-sponsored health plans, and there was also the expansion of Medicaid across the states. How do you get Obamacare? People have the option to purchase Obamacare themselves, either on a federal site such as healthcare.gov, or for instance, here in Massachusetts, we have something called the Health Connector. That's how people will log in and purchase their own Obamacare plan. And who's eligible for that? So really, in order to receive those discounts or tax credits to offset the cost, the household income has to be between 1 and 4 times the federal poverty level. And just to put that into perspective, if someone's job doesn't offer coverage, that's the equivalent of about $88,000 for a family of 4 per year. So making under $88,000, you could potentially be eligible to purchase some of this government-sponsored health insurance. There is the option to use the discounts on the premium so that the monthly insurance bill is lower, or you can wait until the end of the year and declare those discounts on a tax return to lower your tax burden at the end of the year, or potentially get a refund if it's due to you. If someone makes too much money, there are still options for them to purchase through the insurance marketplace. They just wouldn't get any discounts. There are more affordable options available on there for them anyway, so it's worth looking into even if somebody's not necessarily eligible for the discounts that go along with it. The plans that are offered are actually, there's multiple levels of them, so there's different tiers to Obamacare plans. It's very similar to commercially purchased plans. There's 4 levels and they differ in price and cost sharing. And as you know, with the new administration, there has been some changes to Obamacare, but really the major change that most people felt or saw was that the administration did repeal the individual mandate, which penalized Americans for not having health insurance. So if somebody didn't have health insurance prior to 2019, they would have had to pay tax on that basically. And that's been repealed. So there's no longer a penalty for Americans for not having health insurance. And fortunately, there was no changes in the pre-existing condition mandate, which I'll talk about in a minute. So that's just a general overview, and I know most of you are very familiar with it, but I thought it would be nice to kind of touch on that before we moved into what exactly does this mean for insurance plan? What's the requirements of the Affordable Care Act? So the Affordable Care Act requires insurance plans to cover people with pre-existing health conditions. So for instance, pregnancy or diabetes, without charging them more. Prior to the Affordable Care Act, somebody could be actually denied coverage if they had a pre-existing health condition, which left a lot of people without coverage if they had lost a job or things like that. It also provides free preventative care, as you all know, because we do a lot of preventative care here across the network. And so we'll talk a little bit more about that. One of the nice things is it gives young adults more coverage options, and it actually allows them to stay on their parents' insurance until they're 26 years old. So prior to the Affordable Care Act, young adults were the highest percentage of uninsured Americans across the country. The ACA also ends lifetime and yearly dollar limits on coverage for essential health benefits. It holds insurance companies accountable for rate increases. It requires them to put a percentage of their profits into healthcare rather than just large profits not going back into claims and providers. And it also makes it illegal for health insurance companies to cancel health insurance because someone gets sick. And fortunately, those did continue to exist with the changes made by our new administration. So what does pediatrics look like under the Affordable Care Act? So under the Affordable Care Act, insurance companies are required to offer these certain preventative coverages to patients and families without cost and cost share. So that's co-payments, co-insurances, deductibles. And so here you'll see a list of items that are covered there. So alcohol, tobacco, and drug use assessments for adolescents, autism screenings for children between 18 and 24 months, behavioral assessments, bilirubin concentration screening, blood pressure screenings. You can see there's a listing of ages that blood pressure screening would be covered for, depression screening for adolescents beginning routinely at age 12, and developmental screening for children under age 3. And so again, the point of this is that parents can get these services and do these screenings and not have a cost share on it. And specifically for us, we have put in here some of the other screenings: hearing screenings, height, weight, and body mass index, immunizations, lead screening, maternal depression screening, obesity screening, STI prevention counseling and screening as well, and then of course vision screening. We did note up here a couple of these measures are also HEDIS measures, so you're probably extremely familiar with them. But one of the things that I hear often from practices is that they have gotten contacted by a patient or a family who has received a bill for an item that should be considered preventative. So that could be any number of these items. You know, somebody would say, my patient got hit with their deductible for a hearing screening. And so I'm thrilled today to share with you a preventative coverage grid that we have put together. We will share it after today's webinar, and this grid will touch on some of the most common preventative items that we do here at the PPOC, so depression screening, developmental screening. Although the Affordable Care Act requires that, that insurers cover these different items, they don't specify the billing around it. So what that means is, like most of our insurance company policies, everybody has their own policy on what CPT code do you bill, what ICD-10 code do you use, what are the ages that are covered. So we're thrilled to share with you today, after today's call, this grid that we've put together. It's up to date as of today. We actually just looked at policies this morning to make sure we still had the most recently updated policies, and we'll send this out afterwards as an Excel form. When you receive it, we don't have the bandwidth here to continue to update it for you. So once you have it, it's yours, and you should feel free to update it as policies change. At the bottom of this form is links to each of the payer sites where you can find the policies that specifically reference these different areas. And so again, we'll get that out to you with the follow-up after today's meeting, but we think that this will be really useful for you in determining when a patient is reporting that something is falling to a co-insurance or deductible. You know, you can go look at the United policy and see what happened here, why is this happening, and this hopefully will be helpful for you. Perfect. So that brings us to the end of my Affordable Care Act information. Does anybody have any questions that they want to put in? If there's no questions, I'll go ahead and move to our next section. I believe we'll have time at the end, you know, so if you think of something, you know, during the next couple sections, feel free to let us know. And then of course, you all know how to reach me if you need to get me after the presentation today. So our next agenda item is coding modifiers incident 2. And the way that we put this section together is we looked at some of what we consider the coding hot topics. So we pulled some of our practices, we pulled some of the frequently asked questions, and we worked with a professional who I'll introduce, Jim Tudor. He is the Director of Coding and Billing Compliance at Healthcare Compliance Network. Some of you may be familiar with them. They did speak at our last learning community. Jim, if you are there, I will let you go ahead and introduce yourself quickly, and then we can have you take it from here.
I am there. Are you able to hear me okay?
I can hear you perfectly. Yeah, thank you so much.
Awesome. Okay, thank you for the brief intro, Leah. As she mentions, I am with the Healthcare Compliance Network. Some of you are familiar with them, to be sure. In addition to the branch of the business dealing with revenue cycle and chart audits, which is my piece of the pie, we also do a lot of work within the HIPAA, OSHA, EMR compliance, those domains, pretty much anything that's concentric to the world of healthcare compliance, which, as you're all familiar, is quite a bit. But coding and chart audit is my expertise. I have a team of auditors that perform more or less due diligence type reviews for practices who just want to have a handle on whether or not they're billing and coding correctly. And over the last couple of years, we have added a new dimension to my team, which is from the legal perspective. We have partnered with several law firms throughout the Northeast who send over to us clients who have been audited by any one of the payers, Medicare, Medicaid, Blues, you name it. They all basically follow their own variation of the same playbook when it comes to auditing. And what I have seen in that period of time is nothing short of shocking. It's not uncommon for the insurance company to conduct a chart audit, cross-referencing the billing to the documentation. And even though you may think you've got things buttoned up tightly, lo and behold, you get a recovery letter downstream that has sometimes more zeros in that bottom line number than it should. And the truth be told is two truths, actually. Number one, it is defensible. Most of the time when these findings come back adverse, there's usually something that you can do about it. As far as formulating an appeal, they tend to focus a lot on the grayest of the gray areas. And if you know anything about billing and coding, you know that there's gray areas around every single corner. And it only seems to get worse as time goes on. However, I should add that Medicare is looking, I'll speak to this in a little bit, but looking at reducing some of the administrative burden related to billing and coding up in the next couple of years. And the second thing is, if you do get a letter and it review whether you can appeal it or not, look at it as a learning experience, because often these situations can be avoided with very small strokes, very small modifications, which to the physician from a documentation perspective doesn't mean a whole heck of a lot. To an auditor, it means integrating certain buzzwords and phrases that facilitate billing compliance. For example, I'm going to talk about the high-level E&M codes and the requirements with regard to meeting the review of systems and physical exam and whatnot. There's shortcuts that you can use for some of that, and how you phrase the shortcut could be the difference between pass and fail, especially since those are typically associated with the higher level billing codes. So, I think a lot of it is preventable and a lot of it is appealable. I think we figured out recently that over the last 2.5 years, we have saved our clients over $3 million in assessed fines and penalties that they did not have to pay because we launched a successful appeal. So if you ever get something like that, of course, you might want to have someone from an outside viewpoint take a look at the sample anyway. If you're saying, you know what, I know that I'm probably not going to get the results for a couple months here and we just would like to sleep at night, if you can kind of take a look and look at our records to see what way you think this is heading, we're certainly available to do that, and and help defend you if push comes to shove in the end. Next slide, Leah. So I'd mentioned that there are some administrative simplification measures that CMS is considering for the year 2021. And although most of this is going to start out at the Medicare level, as you all know, at some point, all of the other payers typically adapt some variation of the Medicare rules. And one of the things that's being kicked around, and it looks like it's actually going to come to fruition, is removing the onerous documentation requirements associated with the history and the physical examination. In other words, right now, for especially some of these codes we're looking at right now on your screen, the higher level codes require quite extensive charting to make sure that you're meeting the requirements for those subcomponents that are inherent to E&M services. They are going to, again, if it comes to pass as they're saying it will, remove many of those requirements associated with the history and exam and focus exclusively on the time element associated with the codes and also the medical complexity, which is good because the vast majority of physicians out there don't think of coding in the same terms that billers and coders do. They're thinking about, how complex and how time consuming is this patient versus how many systems do I need for that code? That's the way we in the billing universe think of it. So the good news is, and again, it does look like this is going to happen, that there will be rather profound modifications to the guidelines coming up in 2 years. But we've still got 2 years to go. And, I have to say that, when we receive word from a law firm saying that E&M coding is getting some attention from one or more of their payers, it's typically due to aberrant billing distribution patterns. I had a client a couple of years ago who was audited. Consultation codes were the focus, which Medicare ironically doesn't even pay anymore. But at that time, he was billing. He said, "Jim, I've been a good student of yours for years. You see my notes are, 4 or 5 pages long. They weren't superfluous notes either. He was just a thorough documentarian." And he got audited 40 charts. He passed on 4 of the charts, 90% error rate. And the reason why they disagreed, with the other 36, where he was not meeting the requirements on his review systems and also his physical examination. It just simply was a few systems short of the requirements for the higher level codes. He says, "Why did they pick on me to begin with?" So I look at the letter that they sent him. They always send you an explanatory letter that goes into the details to some degree, and it says, "Dear doctor, we have isolated your practice as potential for abnormal billing as you bill 100% 99244. So I can tell you that if you're billing 100% of any one given E&M code within a particular category, it is definitely going to get attention from the payers because the mentality is they figure if you're following the guidelines as they were created, there has got to be some fluctuation in the volume of work that's being performed, in the complexity in the patients, and also the time aspect. There's got to be a bell curve there. If you're billing 100% of one level, don't think that that's a safe zone because it isn't, and in fact, it's a huge red flag. Funny story too, by the way, on that particular provider, those 4 cases that they agreed with, he was unable to elicit a history from any of them because they were demented, partially demented, compromised neurological status. For some reason, could not deliver any history or a full history. And only in the world of Medicare, you're in luck if you can't get a history. They give you credit for a full history. Go figure, right? So he definitely got attention because of his billing patterns. Right now, the hottest of the hot spots on this screen is level 4 established patient office visits. Too many of those is going to get you attention. I think for pediatrics, the billing distribution, it's hard to get that at the national level because obviously a lot of it comes from Medicare. But anywhere in the 35 to 40% range for level 4s, if you're billing, and this is very, very general benchmark I'm about to impart to you, but my experience is if you're 20%, 25%, let's say, off the norm in any one particular E&M coding level, you are potentially on the radar. Now, can I point to a document from Medicare or any of the payers that says that explicitly? No, that's taken from my personal experience in dealing with these situations. In fact, they won't come out with something like that because they feel, okay, well, if we say there's 20% variance, then everyone is going to be toes to the line. it's guilty until proven innocent in the eyes of the government, unfortunately, and those who follow the governmental guidelines. But generally, if you're 20% off or so, within that range, you're probably in good shape. But over that, you could start getting requests from the payers for single notes. Quite often they dip their toes in the water first before they go full tilt on an audit. And if enough of that comes back unfavorable, it can give rise to a larger scale review. Prolonged care is something that appeared to be a godsend for many physicians, because the thought was, how can we, not only those prolonged situations where we're spending a lot of time in the office with the parent, but some of that additional work without direct patient contact, such as extensive review of charts, phone calls, care coordination, things that may occur before or after the patient has left. It appeared that once most of the payers started jumping on the bandwagon for reimbursing those codes, that it was like problem solved. But for the most part, the guidelines are very confusing with regard to prolonged care, and they are very well reimbursed. I know Medicare, I didn't realize you don't have Medicare, but I think for the first level prolonged care code, first hour prolonged care is something like $100 in addition to your base E&M code. But they are definitely a hot spot. Many payers will not even reimburse them unless you send the note up front. So my suggestion would be, and I'm not sure if any of you folks are billing these codes at all. If you are, you might want to take a close look at the provider's documentation and make sure that they're meeting the guidelines, because that can certainly open up some unpleasant doors down the line. Pitfalls, not meeting the comprehensive criteria. I've already mentioned that with the review of systems. For a level 4 new patient, 5 new patient, and also 4 and 5 consult, as I'd mentioned with my physician friend who got audited, you need 10 review of systems in your ROS and an 8 system physical examination. If you have 7 systems in your exam, they're not going to take a look at it and say, well, you know what, this is a complex patient, so we're going to let it go. They're looking for the low-hanging fruit. And if you just simply not meet, you just didn't document a comprehensive service per guidelines, it's an easy mark. Suboptimal documentation of medical decision-making elements. So there's things that are, to some extent, fairly commonplace for physicians, like doing an independent review of the films. You actually chest x-ray ordered or an abdominal ultrasound, you're actually looking at the films. Review and summarization of old records, which typically can happen for a new patient visit. Calling the radiologist if there's an abnormal study, or cardiologist to personally discuss the case. Those things are fairly common. And that being said, many physicians aren't mindful that there's any value in documenting that. And everybody's trying to get out at a reasonable hour and save mouse clicks and keystrokes. But there is extreme value in documenting those things, because they count towards the medical decision-making element of E&M coding. It doesn't necessarily mean that it's the difference between a 4 or 5. Like, I can't tell you, well, if you start doing this, it's all of your 4s are going to become 5s. It's a contributory component to the MDM, or medical decision-making, and therefore it's good practice to get into the habit of recording that type of work when it occurs. It can occur before, certainly. And that's okay to make an addendum in the chart to document certain aspects. And in the event of an audit, you'd have to pull all that relate to the encounter being targeted. But it can be the difference between pass and fail. The folks who are really good at capturing those elements typically pass an audit with flying colors, because the auditors do tend to look more at the medical decision-making aspect than the other elements. Even though those elements are still important to make sure that you capture, the MDM is really the overarching criterion when it comes to the visit levels. Failure to effectively document time-based scenarios. So there is a provision, and perhaps some of your providers are aware of it, to bill on the basis of time if over 50% of the time spent is counseling. And there are right and wrong ways to document that. The gold standard is to say this was a blank minute visit and over half the time was spent counseling regarding X, Y, and Z. I've seen probably 150 different variations, including prolonged visit without any reference to the time, referencing the time like 20 minutes counseling without any elaboration. Things like that can shoot down your otherwise well-supported level 4 or perhaps even a level 5 if enough time is spent. You know, think of your patients with mental disorders and attention deficit, anxiety, and there's a lot of time perhaps spent with the parent, caregiver, and patient to go over everything, you know, compliance with medications and whatnot. Some of those can stretch out to that 30 minutes or more zone. The time threshold for a 214 visit is 25 minutes and 40 minutes for a level 5. And if you're spending that much time, even though level 5s are red flag, if you're spending that much time, make sure that you're billing that particular level. If you're just doing that only when that rule applies for the prolonged discussion visits, you're probably not going to appear on anybody's radar because that's not going to push the needle up to 20% level 5s or anything like that. It's going to nudge it a little bit. And certainly, again, it's something that you want to also take a look at the note to make sure it's a compliant attestation. But I'm a big fan of time-based billing because you don't have to remember all of that other stuff about ROS and exam and whatnot. Next slide, please. So this is a hot spot that I'm sure you are all familiar with. When I get an audit related to inappropriate use of Modifier 25 in connection with, of course, this rule extends to billing an E&M visit in addition to a surgical procedure or other services on the same day, but most commonly applied in your domain, it's the well visit with a problem component. And the rule says that if a significant portion of the well visit is dedicated to managing either acute complaints, either they're sick on the day they're being seen, or you're spending a lot of time managing chronic issues, or some combination of both. You can bill for an E&M code in addition to the well visit code, and the 25 modifier is attached to the problem-based E&M code. The chief complaint is all important here, and I have a recommendation on this that on the surface might make you scratch your heads and roll your eyes a little bit. But when it comes to documenting the chief complaint and by extension the history of present illness, you should make sure that if the intent of the encounter is to do a surveillance well visit and also address the chronic issues or patient is there with a specific problem, that you address that in the HPI and chief complaint by saying, patient is here for a physical, but I'm also addressing something else. Either maybe they have signs of a URI or they're having abdominal pain. Let's say they have CF for one of the mental health diagnoses, and you know that you're going to be addressing all of that. There's no secret about that, but the way you document it is very important because I have seen instances where the provider in their HPI says, patient is here for a physical, doing great, no issues in school, and then all of the routine work. But at the end of the note in the assessment, the physician says, item number 1, well visit, doing fine, continue this and that, get your shots. Number 2, patient has asthma, has an inhaler, no exacerbations. Item number 3, ADD, and so on and so forth. So those issues that are addressed are not mentioned at the beginning of the note in the chief complaint in HPI. And this can be a problem in the event of an audit because for some reason, the folks who work for the insurance companies are very regimented in their bean counting. And that's literally what they're doing. They're using a tick sheet that is authorized by Medicare, Medicaid, to abstract elements. And it sometimes can throw them for a loop per se, if what is tantamount to chief complaint in HPI is documented in the assessment. And I know that sounds ridiculous, because why should it matter where they document it? But it does, and you can remedy this problem entirely by tipping off, quote unquote, the reviewer by saying the patient is here for physical plus surveillance of chronic issues, or patient is here for physical plus acute complaint. By doing that and documenting a problem pertinent HPI where the HPI belongs, that's going to avoid you a whole lot of headaches down the line, because in the end, I mentioned we have a very high success rate in defending our clients who have been audited, and this is one of the things that we do have some success with, because really, does it matter where they put that information in the note? In the end, it is what it is. But nobody wants to go down that path. You should take small measures, as I'd mentioned at the onset, to tweak the documentation so as to render it as bulletproof as possible from a billing compliance perspective. And by just putting things in a different location in the note doesn't seem like it should matter, but it matters a great deal. Okay. Trivial, insignificant problems should not be reported. Truth be told, in my world, it doesn't seem that very often. The physicians seem aware that they can't, report things that really wouldn't in and of themselves justify a medically valid sick visit on another day, per se. More often than not, that there isn't any issue with that. I'd mentioned time. If they're spending a lot of extra time counseling related to the problems, I'm not talking about routine preventative counseling, anticipatory guidance, things that go with the territory in age-based preventive medicine visit. I'm talking about counseling related to the asthma, counseling related to the anxiety. Then, you look at your watch on the way out of the office and say, you know what, I spent an extra 20 minutes counseling regarding them. Maybe the parent has a lot of questions, or the patient. The way to phrase that is to say, I spent an extra 15 minutes, and the operative word in that sentence is extra, without a doubt. When you use the modifier 25, that essentially means I did something extra. So by saying I spent an extra 15 or however much time was spent, and then over half of that was counseling, again, there shouldn't be a need to have to say that part of it, but again, using the buzzwords and phraseology is of paramount importance here. Then you've identified a specific aspect of the service that's related to your E&M code. Said, aha, carved out extra time, here's what we talked about, and that in and of itself will support the E&M level based on the amount of time. Again, 15 minutes extra level 3 established patient, 25 level 4, and 40 level 5 if that situation ever arises. The pitfalls, well, we already talked about that first one, that big and bad HPI and chief complaint being documented in the assessment, or even sometimes I see it the other way around. I think the organization of the note is important to facilitate a good outcome in the event that there's ever a coding analysis performed on that note. In the end, it is what it is. It shouldn't matter. And maybe with the simplification efforts, we'll see less emphasis on needing to organize the note in a specific way. But that's the biggest pitfall from my perspective. Make sure, another one, make sure that you edit the review of systems to reflect positive responses. So if your HPI has 4 or 5 positive GI elements in there, but the cookie cutter review of systems embedded within the note says GI is negative, that's something that will almost assuredly lead an auditor to break out his or her Sharpie and start drawing lines through the note and the evaluation. Well, I can't trust the integrity of this. Now, truth be told, you all know that that's an innocent mistake. There's only so many hours in the day, and sometimes folks don't edit things in the way that, edit the notes as extensively as they should. But again, just small measures can go a long way. So just taking an extra couple of minutes to proof that note and make sure that there aren't any conflicts, that's of tremendous importance. If you find something significant on the exam, let's say there are no chief complaints, there is no history, but you do find something that warrants further study, you can add that to the history after the fact. You know, you can say also discovered today was whatever the issue may be, tenderness and abdominal tenderness or ear infection or something down those lines. You can add it to the HPI. And then, of course, and I'm sure you are all acutely aware of this, you know, the biggest, I don't know if I'll call it a pitfall anymore because most folks are aware, but the patient may not, or the parent may not be expecting a copayment because they're there for their annual well visit, but then all of a sudden they get a bill in the mail, or I'm not sure how you folks handle that up front, but they're not expecting the copay, and the next time they come into the office kicking and screaming saying, hey, you know, I've been coming here for years and you guys never billed a copay, and my insurance clearly says there's no copay for well visits, you know, and you don't have to give them a coding dissertation as to why they got a copay in that particular instance, but you can tell them something akin to, we are bound by the law to code as accurately as is supported. So we can't arbitrarily not bill you for something just simply because we want to avoid the copay. You know, that's disingenuous. So if you, and also, you know, they really don't save anything. If they, let's say a patient has a lot of chronic issues, say, you know what, I can't address those today, come back next week and we'll address everything. Well, guess what? They're going to have a copay for that visit. So they don't really make out one way or another there. I think it's just a matter of how that's presented to them. And again, you don't have to, you know, break out the coding tick sheets. You can, there are ways to get what you need to accomplish there. Next slide, please. So then just touching upon Modifier 25 a little bit more. This is more in the way of a pediatric specific examples here. Appropriate example, 4-year-old child returns for their well visit. Provider notices there's wheezing and shortness of breath, chest x-ray order, neb treatment is performed. There's no one who would question billing additionally for an E&M code in addition to the well visit. Whereas, you know, in the non-reportable sick visit, 12-month child has a diaper rash or something that, you know, again, think of it as, you know, would this really substantiate? I know sometimes a diaper rash can substantiate a sick visit on its own, but, you know, unfortunately, we don't have any official definition as to what is, quote, trivial or insignificant. But things like that, I would probably not bill for because there is extra sensitivity given the fact that you're billing the two codes together, and therefore there's a higher level of scrutiny to begin with. So I think I'd avoid stuff like that. If they have a, you know, otitis media, if they have a lot of chronic issues, you know, no concerns whatsoever. And then just one payer-specific nuance that I've been made aware of. The Tufts health plans, the commercial plans, have been applying the Modifier 25 towards a payment reduction of 50% of the allowed amount. And it is my understanding that as of July 1st, the public health plans will be implementing that change as well. In fact, it's my understanding that the vast majority of payers now do reduce the payment on the E&M code because there is some overlap. I get it. It's not a cut and dry area. You know, you have history for a problem visit. You have history for a preventative visit. You have an exam for both. You know, so there's some of the elements that do overlap. And I think in recognition of that, you see that most of the payers now will reduce payment for the E&M code, and it's usually 50% of whatever the fee schedule typically allows for that particular service. So you can add Tufts public plans to that list. Next slide, please. Just quick word or two about the SL modifier, which my understanding is for your vaccines is hard-coded in EPIC. It's an important that providers talk about editing, choose or picking the code that does not have the SL modifier if it is a privately purchased vaccine, and obviously that can cause some issues down the line if that does not occur. So again, a little due diligence. Next slide. So another one of the hot spots is Modifier 59. Modifier 59 is is denoted as a distinct procedural service. If you read the CPT definition, it tells you basically it's a service that is performed on another body part, anatomic region. It's still quite vague and is used when appropriate in lieu of Modifier 51 for multiple procedures. On Modifier 59, actually, 51 will generate a payment reduction, whereas 59, I believe you get paid in full for both of the procedure codes. In this example here of where 59 would be appropriate, patient presents for sick visit, billed as a 213, and also runs a rapid flu A and B, which is the same code 87804, and the second unit of that is billed separately with the 59 modifier. So question becomes, how the heck do you know when the 59 modifier is actually appropriate? And the best way to find out is to check the Medicare NCCI National Correct Coding Initiative edits. Next slide, please. Which will tell you in no uncertain terms exactly which codes are bundled together and require a modifier versus those code pairs where there's no modifier required at all versus you can't ever build these two codes together, don't even think about it. There's two basic ways you can get that type of information. The first way would be to literally visit the CMS NCCI tables. And I have a hyperlink if you're interested in doing that. I have a hyperlink. This is not to the CCI tables itself, but actually how to use the NCCI tools primer. And I suggest that if you are going to start doing it that way, that you read this first, because it has some pretty detailed and relatively user-friendly instructions for Medicare on how to use the tool. The edits, just because I keep referencing Medicare here, the CCI edits are generally followed by all payers. So don't think, well, this isn't Medicare, so we don't even follow those rules. Most of them do follow the Modifier 59/NCCI rules. So if you go into the hyperlink, it'll tell you how to use that, and basically you're checking, you know, the base build code in column 1 versus the secondary code in column 2, and it will tell you in this screenshot, column F, you can see there's an indicator, modifier 0, 0 indicator is not allowed at all. Number 1, it's allowed, or number 9, just the concept is not applicable for that particular code pair. An easier way of doing it would be if you have folks who use encoder software, such as Encoder Pro, AAPC Coder, Optum. There are a lot of great products that will simply let you pop in not just one specific code pair, but let's say you have 5 or 6, 7 different CPT codes on a claim. You can pop them all in together at the same time, and it will tell you which codes require a modifier and which do not. And also which can't be billed, you know, simply it's impossible to bill code A with code B, that kind of thing. I would highly recommend that you use something like that rather than try to surf through the tables, which is a little bit time consuming and kind of clunky to get around, and you'd see that once you read the instructions. But I prefer encoder software, and I've heard Optum and Supercoder have excellent CCI lookup tools. So I use AAPC, but I'm told the other ones are superior. We may actually be moving over to those shortly, in fact. Next slide, please. Locums Tenems. So this is, you know, I think first and foremost, I have to tell you that this situation here, where you are utilizing the services of a Locums Tenems physician, is primarily intended for situations where you are replacing a physician who is absent. They are out on vacation, hiatus, illness, and it's a short-term deal only lasting up to 60 days. Where I commonly see this goes astray is when the practice is using a locum tenens, not because there's a physician who's absent, but because they're simply trying to get through the volume. They need additional help, so they will, I know of certain arrangements where providers are borrowed from other practices just to help manage volume at certain times of the year. I found that quite often the practice tries to use a locum tenens to supplement the efforts of the core physicians and providers, when really I mean, if there were one word to use here on this entire slide, it's replacement. This is a replacement physician or substituting in the absence of one of your providers. So when that occurs, the way that that works is that you would attach, the billing goes out under the quote, regular physician. And you attach the Q6 modifier to the claim, which means it was provided actually by a locum tenens. The locum tenens is paid for the services on a per diem or similar basis by you folks. As I'd mentioned, this is only 60-day terms, which is another thing too. If you're looking to get through volume, 60 days sometimes isn't enough time. I get asked all the time, is there any way to extend that? And I actually have some questions out to NGS is the Medicare carrier for the Northeast, and I actually have some locum tenens questions that kind of are concentric to some of these concepts, which, Leah, I will pass along to you because I think it'll be good to know and get some clarification. But my current understanding, and so far they provisionally agree with me, is that you can't use it just to supplement volume. It has to be for a replacement situation. And it does not apply to NPPs, non-physician practitioners, such as NPs, physician assistants, and things like that. It was only for doctors. So just a word of warning there, and I think maybe once I get that information, I think the clarification I'm going to get is going to confirm everything that you see here on this slide. But if there's anything contradictory to that, Leah, I will send you that information, and if you could disseminate that, because this is something that is becoming quite popular and rapidly emerging as a hotspot.
Great. And sure. Can I pause you really quickly, because we do have 2 questions that have come in while you've been presenting, and I know the next section that you'll talk about is will probably be pretty in-depth. So if you don't mind, the first question came in and was, when you are counting systems in the ROS, it has to be 10 separate body systems or 10 items. For example, breath sounds are clear, no retractions, no flaring. Is that counted as 1 or as 3?
Counted as 1. 10 different systems is the answer.
Great.
Yes.
Okay. And the next question is related to the locums. When you talk about the 60 days, is that consecutive 60 days or 60 days per year?
And that's also something that I'm seeking to clarify in my correspondence with NGS. So more to follow on that one.
Okay, great. Thank you.
Because that comes up all the time. Yes.
Perfect.
So all right. So if no further questions on locums, we can go to the next slide. So then we have, speaking of NPPs, Incident 2 billing, which is referring to the provision under the Medicare guidelines to bill certain services under the doctor that have been performed by an NPP. And the way that this typically works, and there are many variations to this, as you will, as you'll see shortly, is that in the Medicare Incident 2 scenario, the initial visit for a particular problem is performed by the doctor. The doctor does an initial evaluation and says, okay, here's what's going on, here's what we're going to do, and you are going to see my nurse practitioner, Donna, for follow-ups for this specific problem. When that occurs, and that sounds a little bit too idyllic, I realize, but when that occurs, all of those follow-up visits can be billed, providing all other appropriate guidelines are being met on supervision, someone needs to be in the office and all of that. All of those follow-up visits can be billed under the doctor as Incident 2 visits and reimbursed at 100% of the fee schedule. All of the payers, or I should say not all, but most of your major payers have some variation of that guideline. But let's go over the Medicare. We'll break this down into detail first, and then we'll get into the variations. To qualify as Incident 2, as it says right around midpoint in the page. It has to be part of the normal course of treatment during which the initial service, which I referred to, has been performed and the physician remains actively involved in that course of treatment over time. They do not need to be physically present in the treatment room when the services are provided. There has to be direct supervision, and in the Medicare world, that means someone is present within the office suite to render assistance should it become necessary. Patient records should document all of those essential requirements for the Incident to service. The coding is actually based on the strength of the NPP's documentation. And specifically, all of these elements, the services must be all of the following elements, an integral part of the patient's treatment course. So like I'd mentioned, there's an initial visit with the doctor, sets forth the course of treatment, the NPP follows them for that specific condition and follows the treatment plan and confers with the doctor as necessary. Commonly rendered without charge, included in physician bills. That's one of the Incident to regs. Of a time commonly furnished in a physician's office or clinic, not an institutional setting. So in a hospital-based clinic where you're billing for a facility charge, you cannot bill Incident to under the Medicare guideline. You can bill something called a split shared visit, which is the doctor and the NPP both see the patient, both document, and both attest to, the care plan for that patient. And the NP must be an expense to the physician. Now, getting to the variations, because that's the Medicare rule. The variations, which you see here on this slide, in some instances, Tufts being one of them, they follow the Medicare Incident to guidelines to a T. Now, what I just described is great in the Medicare world because you have a lot of chronic conditions. Not that you don't have them in pediatrics, but you don't have as many as you do in the adult population. So the Medicare rules are kind of like hammering a nail with a screwdriver. However, Tufts, you have fairly high volume there, and it's clear that they follow that. So for your Tufts patients, you're really only going to be able to bill those chronic conditions Incident to. Blue Cross Blue Shield is a whole other animal, and I've been involved with several cases over the course of the last couple of years where the provider got dinged in the event of an audit because they were essentially trying to follow the Medicare rules, which again are kind of clunky, and not following their own unique variation of those Incident to rules. For example, it need not be a chronic condition to bill Incident to Blue Cross Blue Shield. However, regardless of whatever the problem is, the physician has to be, quote, actively involved in the medical decision-making while the patient is there. And the way that this has been explained to me, and it was actually explained to me by a Blue Shield rep who we were conferring with in the event of an audit, which is those instances where the NPP needs to seek out the doctor and confer with them while the patient is still in the office. That is active involvement in the medical decision-making. They say, hey, I've got patient Johnny in room 2, and I think he might be having an asthma exacerbation. You want to come and poke in and look at him? Or, hey, this patient has X, Y, and Z symptoms. I'm not exactly sure what to do. That's the way that they interpret active involvement. And quite often what will happen is, we will see an attestation in a note that says, I attest to the services, and there's a co-signature by the MD, but it really can't glean that there was anything about that particular encounter which would have necessitated kind of everybody stopping what they're doing midstream and conferring, just not that kind of scenario. Now, that's the way it was explained to me. There are lots of gray areas associated in the details associated with the Blue Cross Blue Shield guidelines. But it's clear that they don't intend to bill, you shouldn't intend to bill under the doctor for those situations where, there really isn't any active involvement. It's not something that would require active involvement, just the nature of the presenting problem. You wouldn't seek out any opinion from the doctor while they're there. Those conditions should not be billed Incident to per their advisement. But if there is truly something more about that encounter that necessitates the input of the MD, then absolutely. So you've got to watch out for that situation because, again, I've a couple of real-life horror stories I could share with you on that, and that 15% extra can be a number with a lot of zeros. You know, in the end, especially if they go back and they say, well, you know, we audited X number of claims and we can see that your billing distribution over the course of time has remained constant, so we can therefore surmise that you've been billing inappropriately going back X number of years. The extrapolation is where the horror story really begins. And they can and will do that. Some of these, there's no difference in reimbursement, like Cigna, Fallon, UHC, and Harvard Pilgrim all have their own unique policies, which are not, this is a very confusing issue, and this is the reason why, where there isn't a one-size-fits-all formula. Quite often when presented with this scenario, many practices simply elect to just bill everything out under the NPP, you know, and not hassle about the additional 15% because, I mean, really, you know, I've heard, wish I had a nickel every time I've heard doctors come up to me saying, you know, there's so many different coding nuances amongst the payers. You know, how can I remember all of that? Well, this is a classic example right here, and I'll even defer to the slide that Leah presented earlier. That had the crosswalk that had different codes, different assortment of either CPT and or ICD-10 codes that are accepted. Things like that, you know, drive the providers nuts, you know, and we know it, but unfortunately this is the reality, and the true challenge is trying to find a one-size-fits-all protocol that, you know, meets the requirements 99% of the time, and that's a tall order because of these payer variances. But it's just something that you need to be aware of. And, you know, the way I've handled it successfully in the past is, you know, really take a look at your top 5 or so payers by volume and try to create a policy that's, you know, a hybrid of everything that is somewhat user-friendly for the physicians to follow. So it's a sticky wicket to be sure. There's no way around that. Next slide.
Jim, really quickly, we do have a question that I wanted to address, and I just want to remind everybody on the phone that Blue Cross Blue Shield is a payer that requires any nurse practitioner or PA that is seeing any of their patients, even when billing incident 2, to be contracted with them. So that's just a reminder, when you bring on a new nurse practitioner who's not necessarily being credentialed and contracted through the PPOC, you are required to do that with Blue Cross. So I wanted to remind everybody that. And then we have a question, a coding question, which I will get to in a minute. But while we're looking at NPs, we do have a question. Is it possible to bill incident 2 and direct billing for the same NP based on the type of circumstance around the encounter?
I would need a little bit more in the way of specific details there.
That almost sounds like that split visit you talked about.
Yeah, so let me just go into what the rules are for split visits too. And this is a rule that would not only apply in the facility setting, but you could also do this in the office too. And that rule is if the MD and the NPP both perform a face-to-face visit with the patient. It can be shoulder to shoulder, or it can be sequentially, one before the other. Then in that instance, the visit can go out billed under the doctor. Both providers would have to document a note. The NPP would document a note, a regular SOAP note, progress note, like the way they usually would. The MD can do an attestation note that looks kind of similar to what you would see in a teaching institution, which is, I saw the patient, I agree with the plan of care, and also some degree, they can't just stop there. You have to go up beyond scene and agree. By inserting some degree of patient-specific information into the attestation, whatever the most salient points are about that particular visit, would suffice. So that's the split shared rule with a 50,000-foot view.
Hey, Jim, can I just pause you for 1 second? I think someone has come unmuted.
Yep.
Okay, I think we should be all set. Go ahead. Sorry.
I think we got it now. Yeah. Okay. Yeah, I was done with the split shared, and I'm very glad that you mentioned that part about non-credentialed providers, because That's something I could talk about horror stories, where I have seen big dollar amounts for our non-credentialed providers, which, as Leah mentions, are not with Blue Cross Blue Shield, and I believe some of these others as well. They have to be those that credential before they start seeing patients. There really is no good way to bill. The effective date of their credentialing is the date that they can officially start seeing patients. And I have been involved with cases, and unfortunately, there's not a lot that I can do in that situation. And it comes down to, coding, splitting hairs and gray areas and nuances. Quite often, we can successfully challenge the counterpoints made by the payer. But if some provider just isn't credentialed and they're seeing patients, there's really no way around that. And essentially, everything has to be refunded. That is an ugly situation. I just had 2 cases, not in your area, but the payback was like, in one was $85,000 and another $115,000. Yeah, so it can be bad. You want to make sure that you dot all your I's and cross your T's there to be sure.
Thank you. And we do have a couple other questions, if you don't mind. I'll ask really quickly. Perfect. So somebody said we have to put modifier 25 to well child visits in order to get paid for shots. So what happens when you have a well plus a sick plus a shot? Do you use 2 modifier 25s? We're also having a hard time trying to get paid for depot shots. If you could touch base on this issue, it would be greatly appreciated. We just administer, the patient brings their own medication from the pharmacy.
Yeah, as far as the 2 modifier 25 scenario, I have heard that there are some payers, and I would defer to your billing folks for feedback on this, because they're the ones who are getting the denials. If you need 2 modifiers, i.e. one on the preventive code and one on the E&M code, they would be the first ones to recognize that, and one would imagine that information should be immediately conveyed to the practices for, if it's payer X, you put a 25 on both. If it's payer Y, you put it on the E&M code. If it's payer Z, you put it on the preventive code. I have heard those stories. The coding rule itself from CPT specifically says that the 25 goes on the problem E&M code. Now, I can't guarantee that there aren't other variances, because I'm sure that there are, but I would defer to your claims experience there and confer with those folks managing your receivables and denials to see what the trends are. Now, as far as the depot situation, I would have to look into that one a little bit more, and I can incorporate that into my feedback, my research work, and along with the locum stuff and other topics that I'll be digging into. I do have my homework all set aside here. So that, unfortunately, I'll have to add that one to the list.
Another question about NPs again, in regards to billing direct and incident 2 for the same NP. If on the day the NP works without the MD's physical presence, and another day they work with the MD, can the code be based on the day, the direct when MD is absent and incident 2 when MD is present?
So whatever billing is generated on each day would have to be billed accordingly. The rule says that the MD doesn't have to be, again, physically present. For the most part, these payers don't require physical presence during the encounter, aside from the split shared rule. But there has to be a doctor present within the office suite, so as to be able to immediately intervene should it become necessary. So you just have to take that case by case. If day 1 there was no MD present in the office, that would have to be billed out as an independent service under the NPP. Day 2, there is presence in the office, and assuming all of the other guidelines are met, you could bill that one incident 2.
And another question, a scenario of impacted ear cerumen removal with pediatric ear curettes during a well visit found during exam, or same type of scenario during a chief complaint ear problem visit. Can we claim modifier 59 in all or some of these visits?
So that's an excellent question, and the whole issue with cerumen removal has always been and continues to be a sticky wicket, especially when it comes to billing for visits in addition to the earwax removal. So I can tell you that the majority of payers, let's start with the sick visit scenario. Patient is coming in with hearing loss. Looks in the ear, says there's cerumen in there. Okay, we're going to either remove it with instrumentation, which is a certain code, or with lavage, which is a different code. If in those instances, you would think that that's a perfectly valid modifier 25 scenario, but I am hearing from the grapevine that many payers, even if you use the 25, even if it isn't, even if there's, ACE's documentation from a billing compliance standpoint, there's really not a whole lot you can do to get that office visit paid. Now, it's a bit of a different dynamic if the patient is there for a well visit, which is quite comprehensive. My inclination would be if that's the only issue that's addressed, the only problem addressed would be to bill, in addition to the well visit, the 69210 or 209 code for the cerumen removal, and use the 25 modifier on the well visit. Don't bill an E&M code and on top of that, unless there is something that's completely unrelated to the earwax that is addressed. Now, with regard to 59, of course, you're going to be billing. This is potentially a 59 scenario as well, because you could be billing that along with shots and tests and other services. So you could have, 4, 5, 6, 7 codes on that particular claim. And the only way to really know for sure which codes will require the 59 modifier is to either go into the CMS website to look up the CCI edits, or to use encoder software, and again, preferably one that allows you to put in all of the codes for a given encounter, and it'll just tell you which codes require the modifier and which do not. So the only way to know is really to check.
Great, thank you so much. I'll move forward to the next slide.
Okay. And guess what? That's yours, Leah. I think we were transitioning here anyway.
Yeah, we are. Thank you so much. We have just about 14 more minutes, so I'm going to go through this next section pretty quickly. I appreciate everybody, continuing to remain muted if you don't mind, so we don't get background noise. And so we spoke about nurse practitioners and requirements that are all different based on payers, but one thing that all of you and all of your practices and nurse practitioners need to know is the Massachusetts scope of practice policy. And so you'll see this up here, that there is a written collaboration agreement that's required between the nurse practitioner and the supervising physician. And then there's also a collaboration agreement related to prescriptive guidelines. And please note that both of these items, this collaboration agreement item, is required as part of the PPOC application for nurse practitioner membership. So this is just a reminder. I think that everybody pretty much knows this. When you request an application from the PPOC for your nurse practitioner to gain membership, there is an actual collaboration agreement draft sample in there that you're more than welcome to use and edit and use that with your nurse practitioners. I wanted to just quickly touch on nurse practitioner membership in the PPOC. As you all know, the PPOC does welcome nurse practitioners and PAs as members. I'm happy to say that we have over 100 right now as members of the PPOC. And in order to e-prescribe controlled substances in EPIC, you must be a member. And that's a federal guideline that requires that we verify credentials of any provider e-prescribing controlled substance. And so I just wanted to clarify, because we do get a lot of questions about this. If your nurse practitioner or physician assistant needs to or wants to e-prescribe controlled substances in EPIC, and they want to become a member, that does not require that they contract with the payers. They can still be a member of the PPOC and not contract through the PPOC with the payers. And in fact, the vast majority of the nurse practitioners who are members are not contracted with payers through the PPOC. So if you do want to contract your nurse practitioners or PAs on the PPOC contracts, I have included contact information for our credentialing department. As you could see from Jim's presentation, the requirements for billing for nurse practitioners is a bit challenging. It can be hard to operationalize in your office. And as you all probably have heard, as of July 1st, all Harvard Pilgrim claims for nurse practitioners will be reduced to 85%. There will no longer be the 100% billing under the physician for them. And so many people are making the decision for ease of practice and for convenience of the doctors as well, who might not need to be supervising a NP if they're more independently practicing. We do obviously contract PAs and NPs through the PPOC. So that's just a reminder on that. As always, reach out with questions. Just know that they're not exclusive. You can be a member and not contract. And I will pause here before we move to our next section to see about any questions. We do have a question if we can share the templates for the collaboration agreement, and we're happy to add that with our follow-up from this meeting. And so we'll put that on Anna and my homework list. So not just you, Jim. Are there any other questions? I know we did talk about a lot of information, and we will follow up with some of the takeaways that have been requested. It does not look like there's questions, so I will go ahead into our billing policies and best practices, and we can get through this pretty quickly. So the reason that we wanted to touch on this, the billing policies, is that there are some policies that would be in your best benefit to have created in your practices. This includes items such as divorce and custody, legal issues, well exam policy. So Jim had talked about patients being surprised when they got a copay if there was a well exam and you appended a modifier 25 for a sick visit. So having a policy that addresses that is really useful. It's useful in advance of it. It's useful for your billing department when they're managing those type of calls. And then having policies surrounding insurance and payments and balances. And we know now in 2019, a lot of our commercially insured patients have deductibles and co-insurances. Many people don't understand their plans, and it's impossible for you as providers to know every patient that walks through the door's plan. They could have, multiple different versions of Tufts or multiple versions of Blue Cross. It could be employer funded, could be an HMO or a PPO. And so having a policy, a clear policy that patients receive and acknowledge is really useful. And then we wanted to talk about non-covered service waivers. I know this has recently come up with practices who balance billed a patient and had not gotten a waiver on file. And then the denials and appeals, I think that Jim touched on at the beginning of his presentation. So I think we'll be fine to skip through that. And so, again, I talked about divorce and custody cases. In pediatrics, this is a pretty common issue that comes up, and many times parents will have a bad relationship at this time. And so, the court order might say that dad has to pay for health care, but mom's bringing the child to the office. And how do you manage that? And what's your policy around that? And so we have an example of a divorced parent's policy that we're going to share as one of the handouts from this event. And of course, I always say this, it's really important that if you have legal representation, that you share this with them and that you get their okay on it. We're obviously not attorneys. We're just here to try to help you, to give you information that you can use in your practices to help streamline when you have issues such as this. So definitely, this is not intended to be legal advice for your practice, just something that you can use to create your own policy. And then speaking of the well visits, when you append a modifier 25, we have put together and have actually shared with some other practices already, but we'll share with all of you an example of a posted sign for your exam rooms that address what does this mean if there's a well exam, and if you're talking about things that are outside of the normal growth or development. I like the language that Jim had talked about the legal responsibility to code the visit exactly as it happens. And so I definitely would recommend trying to utilize some of that language, at least giving that to your billing department so when they're dealing with these calls. But this is a type of sign that you may want to put up in your waiting room or in your exam room so patients realize that there may be a copay or a deductible if they come in for their well visit and want to address 12 problems that they held on to until their well visit to try to avoid paying that copay. And so being sure that not only you have a policy, but that your families are educated on that. And how do you do that? Make sure your staff understands. So if your staff doesn't understand, it's very unlikely that your patients and families will. And we'll share this with you. And then insurance and billing policy, what is that? What does that include? What do you put in there? So, some examples here, things that you want to outline. Insurance, that's the type of area where you want to, report that every insurance plan is different. It's up to the patient and the family to understand their benefits. The practice cannot be responsible to understand benefits of all of the patients. What kind of payments do you accept? Do you take flex spending? Do you take credit cards? Letting people know that they can pay online at MyChart. How do you deal with newborns? I have recently talked to a practice who, if the parent didn't put the baby on the insurance plan after a certain time frame, they will not schedule another appointment. So what's your policy around newborns? How long do parents have to get that baby onto insurance? Does your practice balance bill? What's your policy around that? What would force you to dismiss a patient from your practice? Do you have an immunization policy? Do you have a no-show policy? Do you have a financial policy? What type of visit types do you offer? What does that mean? What do you do with secondary insurance? Who's responsible to give you that information? I recently had a practice that had billed out to a commercial insurance. The family did not indicate that they had any type of secondary coverage. They came back many months later stating that they had a secondary insurance at the time of the visit, but the practice had missed timely filing, and now the parent didn't want to pay the balance because they had another insurance. And so these are the type of things that happen, and having these policies and procedures and ideally getting signatures on these really can help you when somebody comes back and says, I didn't know that I needed to tell you that I had another insurance. I didn't know that you would bill me for something that wasn't covered by my insurance. How do you deal with labs and x-rays? Whose responsibility is it to tell you if a patient is required to go to Quest and they can't go down the hall to the local hospital? They need to inform you of that. That's the type of thing that you'd want to include. Advanced beneficiary notices. What do you have people sign if there will potentially be a charge for them? And then again, do you charge patients for no-shows and cancellations? I think that is one of those areas that's pretty varied across the network. You obviously can't charge mass health patients, but some of the commercial patients, you do have the right to charge them if they no-show or cancel their visits. And so we will send out this, again, it's an example. It's not intended to be your practice policy, but it's something that you can use to build your own based on your existing policies. And then I had quickly talked about balance billing, and we did want to just give you this grid that gives you information about balance billing. Is it allowed? How do you do it? If the patient has Blue Cross, what's the requirement for you to balance bill? For the most part, you need to get some kind of consent in writing in advance of the service. So if there's a service that is not covered by their insurance and they want to do that service anyways, you need to have them sign an authorization. This grid here will link you to the policy by payer. So we'll send these slides out and you'll have access to that. And that brings us to the end of the presentation, right in the nick of time. We have just about 2 minutes for questions. I do have one question that has come in. We have nurse practitioners who have been part of the practice for over 20 years. I don't know if they are individually credentialed with each health plan. If we do credential them, will that flag our practice for audit with the payers? So the answer to that is no. The only payer that requires that you credential your nurse practitioners is Blue Cross. So you definitely want to confirm that your nurse practitioner is credentialed with Blue Cross. And if they're not, you do want to go ahead and start that process. It's pretty easy. There's a form you can fill out online. Maybe we can send out the link to that as well. As part of the follow-up, the information on how to contract your NPs with Blue Cross. But the answer to that is no. We did have a presentation in early 2018 where we talked about that specific requirement, which was stemmed from an audit we had from Blue Cross. And so at that point, there was a handful of practices that had reached out to contract their Blue Cross, and to the best of my knowledge, there was no negative audits or anything based around that. Okay, good. So it's 1:30. I want to thank you all for attending. I hope that today's session was helpful. We'll share the follow-up items. We'll have the recording made available to you. And I hope you all have a great summer. Enjoy July and August, and we'll see you back in September.